So thank you everybody for taking the time this evening to connect and to join the webinar. We're really excited to have you here. My name, I'm sure you've seen it in all the correspondence. I'm Jyoti. I'm with Zio Plus. If you're not familiar with our product, it's Ferrocin Forte, and I am the marketing manager for the healthcare professional side. I also have my colleague here, Feroz, who's going to be helping out with the Q&A as well. And I just wanted to go over some housekeeping before I introduce Dr. Rajakumar. So our agenda for this evening is the presentation. The presentation will then be followed by the Q&A. So be sure to put your questions in the chat or the Q&A box, whichever one. Throughout the presentation, we will be making a note of them, creating a list, and then we will do our best to get through as many of them at the end of the presentation. Following the presentation, we have a live raffle. So in order, if your name's called, in order to claim it, you got to be there. So we hope you hang on for that. And then for anyone who's interested after that, we will do a quick little presentation from the Zio Plus side of things on our product offering. And if you have any questions regarding that, you can hang on as well. And we always get this question. The webinar will be recorded, and the replay will be shared within a few days by the end of the week, most likely. Okay, so with that being said, I'm going to introduce Dr. Chandrew Rajakumar. So Dr. Rajakumar completed a degree in engineering at the University of Western Ontario, and as well as a doctorate in medicine and a residency in obstetrics and gynecology. This was followed by a 2-year fellowship through the AAGL in minimally invasive gynecologic surgery with a special focus on endometriosis and chronic pelvic pain, as well as a fellowship in simulation and medical education in the Department of Innovation in Medical Education at the University of Ottawa. So currently, Dr. Rajakumar is the section head of minimally invasive gynecologic surgery at the University of Calgary. He's also the manager of the outpatient hysteroscopy and minor surgery program at the South Health Campus Women's Health Clinic. He's also the medical director of the Advanced Technical Skills Simulation Laboratory. This is a state-of-the-art simulation center at University of Calgary and is accredited by the Royal College of Physicians and Surgeons of Canada. And finally, he is also the president of the section of obstetrics and gynecology for the Alberta Medical Association. So lots of expertise and knowledge here. And Dr. Rajakumar, we're so happy to have you.
Thanks, Jyoti. Thanks for that introduction. It's very flattering. It's my privilege to be here, and I want to thank everybody for registering and coming today, this evening. It's really awesome to see that everybody is engaged in improving themselves so that you're better tomorrow than you are today, for yourselves and for your patients. It's really uplifting. So thank you for coming to this event. Without further ado, I would like to discuss the management of iron deficiency anemia, my approach to it, and some of the perspectives that I have as a women's health provider and also as a surgeon. There's some disclosures that have to be made. So I do have different obligations, and it's important for you to know that this is a paid presentation from Zio Plus. That being said, all of these slides are my own. All of the information that's in here are my own. They are my opinions, and they are also based on peer-reviewed publications and some of the research that myself and my group have done. So take everything with a grain of salt, but also recognize that the best level of evidence that we have has been kind of searched through and is being presented today. Now, this is the kind of path that I want to take you on, and we'll go through the various causes of iron deficiency anemia, and then how my perspective on it as a women's health provider and a surgeon, and how management has evolved over time, and then we'll circle around and take questions after the presentation. So the reason I chose this topic and the reason I chose this image is that anemia has been on the World Health Organization's 100 core health predictors list for as long as I've been in medicine, and definitely a lot longer than that. And iron deficiency anemia is one of our global problems. And this scale can be difficult to imagine. This is something that, as a species, we need to develop a solution for. This affects human beings of all demographics, certainly some more than others, but at the same time, anemia is also a very local problem. So each community can do their part to understand the impact of the disease on whatever scale is relevant to them, and learn from each other, because we're all kind of working at it together, and share in this knowledge so that there can be advancements locally and then on a broader scale. So what are the causes of iron deficiency anemia? Well, it's actually a really complicated question. And so this is a simplification that I've put up there. The problem is now being, in this slide, the problem is in the context of iron homeostasis in the body. The principal means of adding iron to our system is through our diet. In brief, organic iron is primarily found in meat and is reduced from Fe3+ to Fe2+ by our stomach acid, and approximately 30 to 40% of ingested heme is then absorbed in our jejunum, which is part of our small intestine. We do also have a receptor in our GI tract called the DMT1 receptor, also stands for divalent metal transporter, and it's responsible for absorbing inorganic sources of iron, but this is a less efficient process. Ferroportin and transferrin is how iron makes its way from the GI tract into the plasma in our blood, which from there is transported for storage and to our marrow for hemoglobin production. When red blood cells are destroyed, their iron binds to transferrin within our macrophages, the cells part of our immune system responsible for gobbling up all broken cells and recycling that material, and that iron is recycled. Overall, the human body's inborn recycling system for iron is over 95% efficient. So, when we step back and we take a look at this, if we're not terrible at absorbing iron from our diet and we eat every day, and we're pretty excellent at recycling the iron that we use up, why do we even have this global problem? There are a number of reasons, but mostly because we have losses from the system. These losses can be chronic and they can be repetitive, and over time this builds up. And disease states as well affect absorption. So these are some of the main causes of iron deficiency anemia, and I certainly have more experience with the first two items on this list, being principally a women's health surgeon, and I intend on expanding on these elements, but other key contributors to our problem are GI and urinary losses, so gastrointestinal and urinary losses. As well, disease states and obesity and celiac disease, they affect iron homeostasis with a little bit more complexity than iron loss alone. So we'll touch on that. In obese individuals, the incidence of iron deficiency anemia is quoted at 7.9%. The national average is 3%, so a little bit more than double. If we look back at our diagram, the effect that obesity has is that of a disease. So through creating this mild chronic inflammatory state, in these individuals, hepcidin, which we'll talk about a little bit later, levels are persistently elevated. And this elevation in hepcidin levels reduces iron absorption and transportation. And again, you'll see that a little bit later. So you'd think that if we correct some of this obesity, then this should get better. But in fact, when we look at patients who've undergone bariatric surgery, we sometimes see the opposite effect. So some bariatric surgeries can actually reduce the number of parietal cells. Those are cells found within the stomach that produce acid, and therefore there's a limitation in the conversion of Fe3+ to Fe2+. which is, as we discussed, a very important step in the transportation of iron across the gut into the blood or the plasma. And furthermore, dietary changes both prior to and following bariatric surgery can contribute to poor iron intake. Food intake questionnaires of bariatric surgery patients found that 90% of respondents actually consumed less than 70% of their recommended daily iron intake, even 6 to 9 years following their procedures. And one study by Halverson and group showed that 27 out of 69 gastric bypass patients, so about a third of them, experience emesis or vomiting with the consumption of high fiber meats. And if this is your reaction to a particular food, wouldn't you cut that out of your diet? The incidence of iron deficiency following bariatric surgery has actually been cited as high as 50%. However, meta-analysis of case reports and case series puts this number closer to 23%. But that's still a very significant figure, especially when you consider the Canadian average being 3%. This becomes further complicated in obese females as the endocrinologic effects of obesity disrupts ovulatory cycling. Following weight loss after bariatric surgery and ovulation, so not ovulating, is often remedied, but this adds to iron deficiency through menstrual losses. So in some cases, as discussed on the previous slide, the stimulus for ovulation takes place right here in the middle. This is the estrogenic or the menstrual cycle. That stimulus for ovulation is insufficient, and these individuals develop amenorrhea. Now, some individuals, this threshold is a little different, and they cycle normally. And in the rest, which is a large population of individuals, sometimes there's good egg recruitment and sometimes there's not. And this results in what's called anovulatory cycles or irregular menses and causes protracted follicular phases. So that's the early part of the cycle, the part of the cycle here where there's estrogen only without progesterone. And this irregular menses results in excessive amounts of estrogen stimulating the lining of the uterus. And that means that the uterus lining becomes thicker, becomes more vascular, and it yields heavier, unpredictable, and protracted bleeding. So we call this and all of these variations abnormal uterine bleeding. Now, is this a common phenomenon? Is this something that affects enough of the population that it's worth talking about? The answer is, yeah, it is. So worldwide, the ratios are pretty similar. And in general, we can say that 1 in 5 women experience abnormal uterine bleeding. And again, that definition is there on the right-hand side of the screen. And unfortunately, when we look at the North American and the Western European data, we find that only 33% or a third of people who have abnormal uterine bleeding seek treatment for it. And unfortunately, it's also a very common cause of hysterectomy and other surgical interventions. In fact, when we look at Canadian data, so this is data that comes out of CIHI. So it's the Canadian Institute for Health Information. It's a national government-run informatics organization that looks at everything, not just hospital-based things, but in this, and it's all publicly available information. In this publicly available chart on surgical interventions in 2020 and 2021. So I picked numbers from kind of pre-pandemic-ish numbers. And these numbers are very similar to years before, 2019 as well as 2017. And we see that hysterectomy is actually the 8th most common inpatient surgery in Canada. And remember that the technology and the skill set has improved over the last 2 decades. And in fact, a hysterectomy is not commonly done as an inpatient surgery. So the fact that inpatient hysterectomies are so common, and this only accounts for inpatient hysterectomies, remember that the overall number of hysterectomies, it has got to be much larger than that. So this is a photo of a good friend of mine. His name is Dr. Mac Monroe out of UCLA, California. And a little over 10 years ago, he published a classification system for FIGO, which is a global community organization on abnormal uterine bleeding, or AUB. It allows for communication amongst healthcare providers on a more specific, more granular level. Instead of saying that someone is just bleeding too much or too often, we used to use terms like dysfunctional uterine bleeding and menorrhagia, but now we use AUB, and then we divide it into structural and non-structural, and essentially say this person has AUB polyp, AUB adenomyosis, AUB leiomyoma, which is a fibroid, malignancy related, and these other non-structural causes. And it allows us to be specific, and it allows us to be able to communicate with each other a little bit better, because then information isn't lost, and we know that certain investigations should have been done, and what to look for. Now, these are the various OBGYN societies from across the world, and essentially when we culminate these informations together, we see that surgical management should be preferred in cases of essentially what they're saying is structural cause of abnormal uterine bleeding or unsuccessful pharmacologic treatment. And it's true, hysterectomy, if you have a hysterectomy, you'll never bleed or cramp again. But we find ourselves between this proverbial rock and a hard place, because we have these patients that are bleeding heavily. With time, they're incurring, with every cycle, they're incurring greater losses than gains. They're often refractory or intolerant of pharmacologic cycle suppression. And there's usually more to the picture than just bleeding alone. So can surgery stop bleeding? Absolutely it can. But these anemic patients, are they optimal candidates for surgery? The short answer is no, they're not. So let's look at this data here. This is the objective of this study, was to describe the mortality rates and the pattern of intensive care resource utilization in patients with anemia, varying degrees of anemia, and those without, all undergoing non-cardiac and non-neurologic inpatient surgery. So if we consider both of these curves, there's two sets of data here. The curve above shows the probability of discharge from hospital following inpatient surgery. And you see that it's highest in the group without any anemia, the solid line, and it's less in patients with mild anemia, and it's lowest in patients with moderate and severe anemia. And you can see that discharge happens earlier, and also the probability of discharge later is highest in those who have normal hemoglobins. And anemia is defined as 120 grams per liter is the cutoff, and less than that is anemia, and that or above is considered normal. Now, when we look at the curve below, we see this curve has to do with in-hospital death. And again, you see this dose relationship between the degree of anemia and the probability of death in hospital following surgery. This data has been repeated in other studies, and we see this now presented by a different group, published in Lancet about 10 years ago, and they show this data as in odds ratios. So you can see that when a person has anemia, this is a 42% increase in their odds that they have mortality within 30 days after surgery. And again, we're not considering cardiac surgery, and we're not considering neurologic surgery. But these are very significant and very scary numbers. These are also elective surgeries. And then when we look at morbidity, you see a bit of a dose stratification here as well, but a 30% or a 50% increase in morbidity after surgery is something that really quite scares us as a surgeon. And these patients need to be optimized prior to coming to the OR. So how do we do that? So let's talk about what our options are. If we first consider the traditional oral iron preparations, Fe3+ needs to be reduced. That means it needs to be converted to Fe2+. These are transported into the plasma with the help of ferroportin, as I described earlier. Hepcidin, which is that orange box over there, or this yellow box, degrades ferroportin, and it inhibits absorption. So you can see where it affects the iron homeostasis. That which is not absorbed remains in the gut, and it contributes to GI intolerance. These adverse effects can reduce compliance amongst patients. And I mean, we all have patients, and we all have patients who you see in follow-up and they say, oh, I stopped taking that. And you're like, why didn't you call my office? I have other options for you. But this is one of the limitations. The limitations of absorption, GI tolerance, and patient compliance are the reasons for parenteral therapy. Once iron transferrin is produced, iron can be transported to where it needs to go throughout the body, including the marrow. Also remember that in order to make red blood cells, in addition to heme, which is where the iron comes in, we also need folate and B12 for erythrocytosis to make that the cell that encapsulates that iron. Epigastric pain, nausea, and constipation are the most common adverse effects of oral iron therapies, and it reduces the compliance in a large proportion of cases. And in fact, it leads to the discontinuation of therapy in many, 20%, 1 in 5. The odds of discontinuing oral iron therapy in patients with, this is an IBD population, is 6.2 compared to those receiving intravenous replacement. So they're 620% more likely to stop their oral iron therapy compared to people getting intravenous iron therapy, simply because it's not tolerated. And so formulations need to be made in such a way that they're better tolerated, because oral therapy is far more convenient. Enter ferrosome. So this is a liposomally encapsulated iron. There are a number of advantages to liposomal encapsulation of drugs. This is not new to the drug world, it's new to the iron world, but it's used in chemotherapeutic agents, etc. This capsule essentially contains a phospholipid bilayer separating the drug or the payload from its local environment or the GI environment. That bilayer mimics the cell membrane and allows for direct bonding to enterocytes, so you don't need to rely on transport molecules, and it delivers the drug payload directly into the recipient cell cytoplasm, right inside of that cell. It is a little bit more complex than that, but he and group described the role of modifying various liposomal compositions, as well as polymer coating, polymer coating the liposomal surface, adding charge, adding ligands to the surface of these encapsulation compounds. And these can change everything from GI stability to the ability to bind cells, permeability into cells, and as well absorption. And the big thing that it avoids is it avoids a lot of GI intolerant symptoms. So we decided to look into this when the Scio Plus product came on the market, and we didn't see any data with regards to iron. And so my resident, Dr. Manuel, together, she and I recognized that there's a significant gap in the women's health in Canada with regards to iron replacement. And as I stated earlier, 1 in 5 women who are of reproductive age suffer from abnormal uterine bleeding. So we looked at the data on GI tolerability of liposomally encapsulated iron and essentially found nothing that was out there, especially in women. And we found validated questionnaires on GI tolerability. We did an assessment of power, and over a 60-day period of time, patients received this product for iron replacement, and we essentially used a validated GI tolerability questionnaire for iron to see, is it true? Do patients actually feel better? And as a result, does that mean that they're going to be more compliant on this medication or this health product? So we included 10 patients. That was what our power calculation showed would show a difference. And one patient took only 40 days. They lost one of their study packs. And there's still data being collected on the last 1.3 patients, so the last part of one patient and one whole patient. And so we have some preliminary data that Dr. Manuel will publish at whenever she's done her Royal College exam, I suppose. Interestingly, when you look at this data, you see that no participants exhibited any vomiting, heartburn, headaches, or diarrhea. 1 of the 9 developed some moderate nausea towards the end of the 60-day period, which is unusual for, you'd expect it to happen right off the bat, not prior. 2 of the 9 had worsening abdominal pain at the midpoint. 2 of the 9 had worsening constipation, but 2 of the 9, the same amount, had improvement in constipation over the 60 days, and 1 of the 9 had no change in constipation. Interestingly, when you look at this, there was a singular patient who was the patient with nausea, who also had the abdominal pain and the worsening constipation. They actually stated on the questionnaire that, quote unquote, "I love this study tablet much better than my other iron." So in all likelihood, they had actually an improvement. It's just that the way that the questionnaire is worded. At the end of the day, the data collection needs to be finalized and the analysis needs to be a little bit more robust and statistically done. At the present time, though, we have a complete data set on 7 patients, and 6 of those patients have completed all their blood work. And we see that the average increase over a 60-day period of time was 34 grams per liter. That's very equivalent to if a person was receiving parenteral or intravenous iron therapy. In fact, there's only one study out there that compares parenteral IV therapy to oral liposomal iron, and it doesn't perfectly fit our population, but this is a population of individuals who have chronic kidney disease. That urinary losses is one of the contributors to iron deficiency anemia. And what you can see is that the initial rate of increase in hemoglobin was significantly higher in the IV iron group. That was within the first month of treatment. But following this, the differences lost significance. And what that means is that essentially, if you give somebody IV iron, you get it into the system right away. That's pretty obvious. But that after a month, the rate of hemoglobin change is no different between liposomally bound oral versus intravenous. So let's go through a case together, because I think that will help kind of wrap this up and put things into context. And this is an actual case. The only thing I've changed are the initials of the patient, because it's obvious, FE, just to be branded with the presentation here. But this is an individual who has abnormal uterine bleeding, and they've had abnormal uterine bleeding for about 2 or 3 years at this time. They've had 2 spontaneous vaginal deliveries. They have a past medical history consistent with fibroids, and really nothing else, fibroids and just iron deficiency anemia. Their blood work shows a hemoglobin of 94 grams per liter. And remember, what we would like to see is 120 or more. Their only medication at this time is ferrous gluconate, which they take twice a day. So this individual was trialed on a levonorgestrel intrauterine system. Levonorgestrel is a great progestin for progesterone receptors. It has the highest receptor affinity of all progestins that are out there. And she found it effective for 3 months. But then, unfortunately, her heavy menstrual bleeding resumed. So she then went for a consultation to see a general OBGYN, and she was around age 48 at that time. The average age of menopause in North America is just over 51. And she was trialed on tranexamic acid and had a repeat sonography done. That US stands for ultrasound. Tranexamic acid is an antifibrinolytic. It stabilizes clot formation. Anyway, so she was then followed up, and she has ongoing heavy bleeding. Ultrasound confirmed fibroids. An endometrial biopsy was done because international guidelines demonstrate that the probability of endometrial cancers are higher in this age population. And if you find it at this age group, the probability of a complete cure is much higher. And the endometrial biopsy was unsuccessful, likely due to the morphologic changes of the fibroid. So she follows up a month thereafter to have a hysteroscopy, a tiny little camera passed through the vagina, through the cervix, and into the uterus, and a visual guided biopsy of the endometrial lining. This comes back benign. She still continues to have ongoing bleeding, has now been suffering for almost 4 years, and is started on a Provera, which is a different kind of progestogen, and it does have a breakthrough bleeding rate, but it's systemic. And so can we stop ovulation? Can we stop menstruation? Ongoing heavy bleeding. And so she is consented for a hysterectomy due to the morphologic abnormalities of the uterus. She sees me in clinic, in our minimally invasive surgery clinic. At that time, her hemoglobin is a little bit lower, very similar to what she started out almost like 6, 7, 8, 9 months ago. And we talked to her about the study, and we started her on ferrosome. And as well, I started her on B12 folate, and she gets an injection of leuprolide acetate. And leuprolide acetate, unfortunately, she can't afford it, and so we have to arrange surgery relatively soon thereafter. And leuprolide acetate costs between $350 and $400 per month in Canada. And so she has a laparoscopic hysterectomy, very minimal blood loss. And when we follow up with her a month after that, she has a hemoglobin of 130 grams per liter, excellent, and she feels much better. Fatigue and other symptoms have improved significantly. She says she's healed, or we say she's healed, and she says she's very grateful. Now, this looks like a huge victory, but in fact, it's not a huge victory. This is unfortunately the mold for most women within their kind of mid to late 40s who have fibroids. And remember, almost 70% of women have fibroids, and 20% of people have abnormal uterine bleeding. And unfortunately, this person has been suffering for 4 or 5 years before, and anemic for that time before their anemia has been corrected and their pathology has been treated. So it seems like a victory when we go through the case, but really, what we know is that we have a lot better that we need for our patients. GI tolerability of liposomally encapsulated iron, it's good. Hemoglobin increases really quite well. 34 grams per liter per 60 days is fantastic. It's a small series, but more studies need to be done. This is at least a jumping point for scholarship, where others can then do these studies in various disease settings, in various clinical settings, and using different study designs so that we can kind of get contextual rationale for using iron in our patient population. And over a 90-day period of time, similar rates of hemoglobin improvement compared to intravenous iron. So something that's very promising here. I'm happy to take any questions.
All right. Thank you so much for the presentation. We have a ton of questions, so let's just jump right into it. So the first question is, what is the percentage of IDA that is idiopathic? So no cause found despite extensive investigations.
Yeah, that's a great question. So I didn't put idiopathic on that list, but you're right, about somewhere between 15 and 20% of iron presentations, we don't identify a cause for that. And that's even true in women's health. And so I imagine that number must be true for men's health as well, and also in elder care, that there's a population that have iron deficiency anemia as well, and we don't identify microscopic losses in the urine or the GI tract.
So, okay, the next question is, isn't Ferromax dissolved in the intestine? What's the difference then with ferrosome?
Yeah, so the big difference, so Ferromax is it's not coated. It does dissolve in the intestine and has to do with its binding agent, and so it does bypass the stomach, but it doesn't necessarily bypass the gut, right? So what you need to recognize is that when you have iron in the gastrointestinal system, anywhere within the gastrointestinal system, it does cause GI effects. It doesn't necessarily cause reflux, and it doesn't necessarily cause emesis, but it does cause symptoms of bloating, constipation, and abdominal pain. And that's kind of true across the board. Even if a patient has things like gastrointestinal ulcers, and they have bleeding into their small intestine, and then all throughout they carry that iron in their GI tract, they have similar symptoms. So you're right, Ferromax does bypass the stomach, but it doesn't bypass the gut, and there's still leftover iron within the small and large intestine.
Okay, thank you. Can you discuss the diagnosis and management of iron deficiency without anemia, particularly in the setting of an inflammatory condition such as RA or rheumatoid arthritis?
Yeah, absolutely. So there actually have been a couple of studies that are a little bit older now that show that even without checking iron levels and the various ways in which that's done, be it ferritin, be it total body iron, whatever, there are some data that shows that even individuals taking iron supplementation compared to patients who are not all comers, those people testify on quality of life questionnaires that they feel less tired. And that's really quite interesting because they're not making more hemoglobin. So presumably there is a difference in the metabolics that are involved with the processing of iron, as opposed to instead of just looking at the production of and the maintenance of red blood cells. So some people have low amounts of iron, but not necessarily not necessarily anemic. Also remember that when we look at people with low iron and we look at people's hemoglobins, if that hemoglobin is normal but not necessarily high, they may be turning over their red cells very quickly, and that requires energy. And when you are making red cells and you're burning calories in doing so, you don't have those calories elsewhere, right? And so it makes sense that, of course, you're going to feel tired, you're going to feel fatigue. So it may be that the rate of red cell production is high enough that that person is not anemic, but they are iron deficient and they are using their stores. We do also see it in lots of chronic inflammatory conditions. So in my world, it has to do with people who have endometriosis and people who have inflammatory bowel disease. You see that their ferritin levels are often a little bit on the low side and their hemoglobins are quite normal. And I imagine that part of it has to do with, one, the chronic inflammatory state affecting the amount of hepcidin that's available, which is degrading ferroportin, and so disrupting iron transport, not just from the gut to the plasma, but even from the spleen back into the plasma. When red cells are destroyed in the spleen, that iron has to go somewhere, and if it's not going back into the plasma, then it's going to be secreted and lost in the GI tract through bilirubin, etc. And so there are other mechanisms of getting iron out of the body. And so chronic inflammatory conditions affect that whole iron homeostasis pathway.
Okay, thank you. So how important is it to do a hysterectomy in a relative asymptomatic patient, but with a 8.8 centimeter intramural myoma?
That's a very specific question. The short answer is it's not important. What's important in a person who has fibroids or leiomyomas or myomas is whether they're symptomatic or not. So about 70% of Caucasian women have fibroids, and about 80% of Black women have fibroids, and only 40% of fibroids present with symptoms. That symptom may be a mechanical symptom, so does it create a bulk or pressure effect? It may be mass effect pushing on other organs, bladder, rectum. They can sometimes be even large enough that they are causing respiratory symptoms. So a mass effect. The fibroids can also be causing abnormal uterine bleeding or dysmenorrhea, which is pain with uterine contractions. The other thing that fibroids can do is they can sometimes produce hormones. And the hormones that we're talking about are things like some fibroids can produce erythropoietin, and a patient can actually become have a too high of a hemoglobin and become have hemochromatosis. They can also it can also affect calcium balance through ectopic production of parathyroid hormone. So if there is a medical reason or there's a quality of life reason, then surgery for that fibroid can be done, and it can either be done directly on that fibroid, or it can be done on the uterus, or it doesn't need to be surgery. It can be an intervention that stops the cycle or shrinks the fibroid. And there's lots of different ways of doing that. But the short answer is only if the patient is symptomatic or medically compromised.
Okay. So what are your thoughts on absorption of iron by glycinate versus ferrous fumarate, excuse me, / sulfate sources as a non-heme iron source?
Yeah, so there are different mechanisms of transport, and when we look at some of the studies, Dr. Manuel and I looked at some of these iron absorption studies, we find that pretty much across the board, iron absorption is very similar to non-pregnant individuals of reproductive age, except for polysaccharides. Polysaccharide-bound irons are tolerated a little bit better and absorbed a little bit better. The pharmacokinetics of some of the irons require multi-dosing. So like gluconate, for example, is dosed up to 3 times a day in order to be able to transport similar amounts into the plasma. And so, I mean, that's where we have to listen to what the patient's side effects are, because they don't all get side effects. So certainly, lower doses and more frequent dosing intervals may be the way to go for your patient. And also remember that part of a person's quality of life is also their financial quality of life. And so when they're paying for formulations, you have to take that into account and kind of figure that out based on the overall picture of that patient. I saw something that popped up in the chat about, is that safe in pregnancy? Iron is safe in pregnancy. Iron is part of pregnancy vitamins. And I believe that ferrosome was recently, the Society of OBGYNs of Canada made a positive comment with regards to ferrosome. When a fetus is developing and an embryo is growing, there is a known amount of iron extraction from the maternal side, and so in pregnancy, people do become iron deficient, but not necessarily anemic, and so sometimes it's overlooked, but it should be treated because the baby will take whatever it wants.
So that's a good segue into the next question. Is there an ideal dosage, or what was the question here? Oh no, what is the ideal ferritin level for preconception to avoid iron deficiency anemia in pregnancy, or even just iron?
So, we generally just recommend that the amount that is in a common prenatal vitamin is kind of appropriate for supplementation, but I think that providers should check. And generally, like when we use ferritin for the most part, we like ferritin levels of at least 20. And there's a huge range on ferritin that is acceptable, and so being anything above 20 is considered good in our world.
So there's a few questions regarding this. Which lab value is more relevant, ferritin or hemoglobin?
So it depends what you're looking at, because they're looking at two different things. Hemoglobin is clinically the most relevant. And the reason is because the objective or the context that you're looking at it in is the body's oxygen carrying capacity. The body's oxygen carrying capacity is directly related to how much hemoglobin a person has. You could have all the iron in the world, but if you have no hemoglobin, you're not going to survive. The future consideration is the production of new red blood cells, and so to make that heme, you need iron, and to make the red blood cell itself to undergo erythrocytosis, you need to multiply cells, so you need pyrimidines, so you need to supplement pyrimidine synthesis, which means you need folic acid. Which is an integral step. It's a rate-limiting step in pyrimidine synthesis, which is part of making new DNA. And you need B12 because it contributes towards new cell production. So hemoglobin is the most relevant from a right now perspective, as far as getting oxygen to all the cells of your body and potentially your developing baby. And but ferritin and iron is very important for the future production of red blood cells.
Okay. So how significant are the symptoms of iron deficiency prior to the hemoglobin levels, like, truly dropping?
Yeah, so it's an early warning indicator. So when you have symptoms of iron deficiency, such as fatigue and sleep disturbance and things like that, it's a good indicator, especially as a primary care provider, to say, hey, maybe this person has iron deficiency. Let's check that out and see what's going on. Because remember that when you are iron deficient, you are actively trying. You are probably making enough red blood cells, so you're using up your iron, and so you are expending energy in doing so. And so at some point, there's not going to be enough to make more red blood cells. So if you see that your patient is iron deficient, number one, you need to look for a cause, and number two, you need to replace it.
There are so many questions. I'm just going through this. Okay, well, this is a good one. So it says it's regarding a maintenance dose of iron. Should someone be on iron all the time? Like, at what point do they stop, or is it a lifelong thing?
Yeah, so in certain patients, it might be a lifelong thing. If they have a chronic inflammatory condition or chronic disease state, they may need to be on iron for the rest of their life. But in everybody else, we need to identify the cause, and we need to treat the cause. And once the cause is treated, then the reason for iron deficiency should go away. And once they're corrected, they should stay corrected, and then they could discontinue their iron therapy. Okay. So many times in women's health, it's almost always abnormal uterine bleeding. And we've gotten quite good at treating abnormal uterine bleeding non-surgically. And so you replace iron, you manage their cycle, and once the cycle is once they're acyclic or amenorrheic, then when you follow up with them, you repeat the blood work, and if their ferritin has normalized, you can tell them to stop taking their iron. And they're usually extremely appreciative of that, because it's a cost, right? And so once they're able to stop that, and also these are all young people, right? These are all people who are between the age of 15 and 55, 65, and so a lot of the time, being on iron is their only medication. And when a person is on medication, they feel medicalized, they feel like something is wrong, they think of themselves as imperfect, etc. And so being able to get them off medication, even if it's a supplement, being able to get off of it is fantastic for someone's mood.
Of course. So at what stage would you recommend a patient take IV iron versus a liposomal iron?
So because you can get iron into their system very quickly, and if a person is really refractory to being able to stop the cause pharmacologically, and you have to get them in for surgery, then you give them IV iron in preparation for surgery. We saw in the data that it can increase hemoglobin values by the end of 30 days, right? So if you can get their hemoglobin more optimized, then the probability of negative outcomes from surgery is lower. And so it's always a cost benefit analysis when it comes to deciding on preparations. Now, if a patient has no GI intolerance and you're able to pharmacologically suppress their cycle or do something to make the cause paused, then you can put them on oral iron therapy for as long as you need until you can get their iron deficiency anemia corrected. So it's a very individualized process, and a lot of it has to do with timelines as opposed to what works better. Now, if you can't get the cause under control, let's say somebody's has abnormal uterine bleeding, and month after month after month, whatever hormonal preparations you've given them, they can't tolerate for other side effects or symptoms, or they have a history that precludes certain preparations, and you find that that their hemoglobin values are just going down and down and down, then you just need to do whatever and get the most amount of iron in their system right off the bat in preparation for a surgical intervention. And in that situation, it's intravenous iron. We can't get it in faster than that.
Yeah, okay, that makes sense. So I think maybe we can do 2 more questions. Let's see, depending on what the answer entails. So this one's kind of a broad question, but I think that it's a good one. How do you address anemia of chronic disease or anemia of inflammatory disease? Like, what's your
Counseling?
Counseling?
You mean like from a patient counseling perspective?
Like, what is your protocol? Like, how do you address that?
Yeah. So when you identify that a person is iron deficient, or that a person has iron deficiency anemia, and you recognize that they don't have specific losses, and you then recognize that a person has a chronic illness, and the counseling becomes very important at that point. So you have to let the patient know that, look, you have this chronic condition. Let's say it's rheumatoid arthritis, and you normalize the situation and tell the patient, look, I mean, there's no way for you to know this, but when a person has a chronic inflammatory condition, what happens is that there are localized problems that are specific to that condition, and then there are generalizable problems with regards to health. And one of these generalized things that is common to a lot of people who have some kind of a chronic disease is that they become iron deficient and they may become anemic. And so in that conversation, the patient then says, oh, okay. People love to have a rationale for something. So if you know that they have a chronic illness, you can tell them why they have iron deficiency anemia, and then it makes sense. And then you know that you're treating both of those things, and that the treatment of both of those things together will, work together to improve their quality of life and long-term outcomes, etc. But I don't know if there is a different way of approaching, or a different way to approach a person who has a chronic illness versus an acute illness, because at the end of the day, you're making the same corrections. You just have to put it into a different context, so that the patient needs to recognize that they need to advocate for their own health as well. And the ball is not in the patient's court, or in the physician's court, or in the pharmacist's court, or whatever. It's the healthcare team includes the patient, and the patient needs to take care of themselves as well. So if you tell a patient, hey, you know what, have this chronic condition, as a result, you have iron deficiency anemia. I need you to take care of that, and I'm going to give you these things and these tools and this education to take care of the iron deficiency anemia as well. But you have to do that. I'm giving you the resources, and then you can come back to me for support, right? So integrating the patient into the team and saying, this is your responsibility as much as it's my responsibility, is really an important part of that conversation.
Okay. And then another question on the lines of hepcidin and inflammation is, there's some research showing that oral iron supplementation may increase hepcidin with daily dosing. Is potential upregulation of hepcidin avoided with ferrocin?
Yeah, so we don't know why, but there's in the discussion in these papers. So I haven't read all of these papers, but in the discussion in these papers, there's some thoughts that some gastritis and some enteritis may act in the mechanism of a chronic inflammatory condition. That ongoing irritation of the gut leads to certain biological changes, and that also includes increasing the amount of hepcidin. There's also changes in a lot of other things that they think that may be the reason why it. So things like serotonin changes associated with gastritis and enteritis may be the mechanism that's involved with because the GI serotonin controls a lot of GI prostaglandin production, and those prostaglandins are theorized to be part of this mechanism. So I don't know completely, but it is true that ongoing gut irritation of any kind causes hepcidin levels to be elevated, and that's true for people who have true GI allergies, and also people who have inflammatory bowel conditions like ulcerative colitis and Crohn's disease.
Okay. And our final question is a simple one. So it's asking, or they're asking, which do you prefer, or when do you decide which format to give, the capsules for ferrocin or the powder?
So I have actually only given the capsules. I don't know how to choose between the two.
Okay.
I only actually have experience with the capsules.
Okay.
And my patients, I mean, my patients usually come to me on iron, and I usually say, hey, do you want to try this out for a month and tell me if you like it? If you don't like it, go back to your old one. And they usually like it. I mean, I haven't had anyone say, no, put me back on the old one.
Okay, well, that's great to hear.
Yeah. But I've never tried the sachets. But I mean, can you tell me?
Yeah, well, the main difference is, so for the capsules are 30 milligrams, and there is the vitamin C added in there, and then the sachets are 21 milligrams, and then they have a variety of other vitamins like B12, folic acid, vitamin C. But I just wanted to bring up one point, maybe, Dr. Rajakumar, before you go, if you could just, because I'm sure some people are going to have this question. We always get this question. The amount of iron within ferrocin or liposomal iron in general is lower than what you would see regularly in like a Ferromax or another product, right? Like the 21 and 30 milligrams. So could you just clarify for everybody listening as to like why it is lower? But maybe like speak to the
Yeah, and so there are no studies that show why it needs to be lower, but the idea behind it is that liposomal encapsulation. So what the liposomal encapsulation, what it means is that you basically have created a false cell membrane around the iron itself. And because it is a cell membrane, or because it looks like a cell membrane, it's able to go to other cell membranes and attach itself there and then become incorporated into it. And as it does that, it actually pushes its payload into the cell, which means that the absorption, because you're absorbing through mammalian cells, is so much higher, you don't have to have as much drug in the payload. That's why the total amount in the amount that goes into the mouth can be less, because the amount that gets into the cell is actually more. There's less wasted.
Awesome. Thank you for explaining. It's always like a point of confusion for some people. So thank you. You know, we have so many other questions. We could go on for another few hours, but I think we're going to call it a night. So thank you so much, Dr. Rajakumar, for your presentation and sharing your knowledge and your expertise. We really appreciate it.
Thanks for having me. It was my pleasure, honestly. Thank you.
Great. Well, have a great night.
Thank you.